It is the nuances in the care of elderly patients with ACS and STEMI. I just want to discuss upon under the subtitles the prevalence or percentage of the population of acute coronary syndrome in elderly versus non-elderly, and the manifestations which are atypical in the elderly population I will touch upon, and the treatment strategies, conservative versus invasive, and what are the nuances in that. Also the dual antiplatelet therapy, what are the concerns in using dual antiplatelet therapy in elderly. As we go into the National Health NES survey, we know that the patients who are octogenarians will have 5 times higher risk of having an MI when compared to under 40 population. Also from the large crusade registry, we know that the mortality increases steeply after 65 years of age. Also the type of ACS varies between elderly and non-elderly. If you look at the patients after 65, the NSTEMI forms almost 40% of the population when compared to STEMI population. STEMI population is more in the under 40 or under 55 years of age from the insights of the GRACE registry. Although the population of elderly has a very high prevalence of ACS, the manifestations of ACS is totally atypical, especially after 75 years. If after 80 years, only 40% of the patients will have a typical angina. Most of them will have atypical symptoms like diaphoresis, dyspnea, and more often presents with heart failure symptoms compared to the typical angina. We have the challenges in interpreting the ECG also in ACS, because the older population will have a lot of abnormal baseline ECG changes like conduction system disorders, LVH, prior MI. Also in interpreting the cardiac troponin, basically the aged population will have a baseline abnormal elevation in cardiac troponin, but still the age, the specific threshold has not been endorsed by any guideline recommendations. You see the challenges in the treatment of ACS in elderly population, because they are the population less likely to receive the guideline recommended therapies. Obviously, only less than 10% of the ACS trials have recruited patients of more than 75 years. So we have to treat such patients with the marginal evidence from the limited randomized control trials. Coming to the conservative versus invasive strategy, when we go into the large registries like GRACE registry, CRUSADE registry, as well as the large randomized trials like OASIS and CURE, you can understand that the medically managed patients population is varies somewhere from 40 to 70%. And in fact, the utilization of catheterization in the hospitalized patients were very low, up to the mark of 40 to 60%. This again brings the question, what is the reason for not choosing the invasive strategy in the elderly patients? Obviously, when we analyze deeply into the CRUSADE registry, the medical comorbidities, there is a renal insufficiency, advanced age, high risk of bleeding and active bleeding forms a major reason for not choosing the invasive strategy. And again, age is a predictor of early mortality. In the previous trials, GRACE risk score of more than 140 forms a high risk of mortality. Of course, the current 2020 ESC and STEMI guidelines do not endorse the GRACE score. So again, age is the predictor of early mortality and also the bleeding risk. When we look into the academic research consortium for high-risk bleeding, with the major and minor criteria, we need to have 1 major and 2 minor criteria. The age more than 75 itself is a minor criteria, and obviously getting 1 more additional minor criteria is not a difficult one. So these are the elderly people who carries very high risk for bleeding, so we need to tailor therapy accordingly. Again, the ischemic risk is higher in such population. If you look at the ISAR-REACT-5 trial, the ischemic risk is almost 2.5 times higher in elderly population when compared to non-elderly. Similarly, the bleeding risk is higher in the elderly population, almost around 2.5 times higher risk than the non-elderly population in the ISAR-REACT-5 trial. In addition to that, the comorbidities, also the challenge, the increased prevalence of atrial fibrillation in the elderly population. Obviously, anybody who is more than 65 years, which forms a high risk for bleeding as per the Hasbled score, and especially the fatal intracranial bleed, in which the independent predictor is an aged population as well as the aspirin at randomization. If we look carefully, the Asian ethnicity itself will have a increased hazard risk of developing intracranial bleed. So these are all the things where we need to understand the utility and futility, safety as well as the efficacy of using antiplatelet therapy. So the real dilemma is, do elderly patients benefit from invasive strategy? This is a slide from the 2020 ESC NSTEMI guidelines, and the decision has to be made on the basis of the ischemic and bleeding risk, the life expectancy, especially the elderly population, comorbidities, the need for immediate non-cardiac surgery, so we need to stop the antiplatelets in the time, and the quality of life. Frailty, that is loss of biological reserve in such patients, may alter the physiology and the metabolism of using antiplatelets. Cognitive and functional impairment in elderly patients where over-treatment or under-treatment of the antiplatelet therapy may happen. And of course, the angiographic anatomy which decides the revascularization. So keeping in mind all these criteria, it is not so easy to decide on the management of ACS in an elderly population. This is a so-called after 80 trial. The interesting thing is all the patients were 80 years. If you look carefully into the study design, almost 4,187 patients were enrolled, whereas only 457, 1/9 of the patients were assigned to that study. So remaining 3,730 patients were excluded because of the age-specific criteria which comes into the exclusion. That is, they may have a short lifespan, they may have an ongoing bleed, so naturally they will be excluded from the trial, and the unstable nature which may push them immediately for revascularization, not waiting for the study. But despite the odds, these patients are very much benefited by invasive strategy as per this graph. And also, though this is a very small trial, this trial sets the cutoff age for upper age limit for submitting the patients for invasive strategy. The upper age limit almost goes to 90 to 92%, though having a study design limitation of small sample size. This is the ongoing trial by the British Heart Foundation. This trial obviously is, the results are awaited in 2024, will definitely be a game changer and impact the guidelines and practice pattern. Let me go to the case example of one or two of my cases of high-risk PCI. 68 male diabetic hypertensive admitted with NSTEMI, LVF, non-sustained VT with a left main and triple vessel. Two surgeons refused because of the acuity of the illness. They wanted them to be stabilized, but the patient is going in for further worsening. So we wanted to take this patient for IVAS guided, impella protected or supported multivessel PCI. These are the hemodynamics. Whenever I do with either a cardiogenic shock or an acute heart failure patient, I always go with the right heart hemodynamics as well as the LVEDP. The LVEDP is high, the wedge pressure is high. So we did impella supported left main and double vessel stenting of the LAD and LCX. The left main stenting was done in a type fashion. This patient initially was not only for the acuity, also one of the surgeons felt the LAD was not much graftable, suitability for graftability. So again, the final angiogram and the IVAS showed a very good result. The LMCA showed almost well-opposed stents with the MSA of almost 20 millimeters square. So again, another patient with a 72-year-old lady, male, with only diabetes as a comorbidity, presented with the NSTEMI, LVF. Main challenge is recurrent VT, got multiple DC shock, and 2 inotropes and NIV. The number of inotropes matters for the mortality also. The echo showed a global hypokinesia, severe LV dysfunction, and the right heart hemodynamics showed elevated PCWP with elevated filling pressure. So in this patient, having got a recurrent VT and hypoxemia, LVF, and also for some logistical reasons, we supported with ECMO and unloaded with IABP rather than impella. So this patient, we put a cannulation. This is for the impella venous cannulation. And then we just did an angio. The angio showed after the diagonal, the LAD is totally cut off, very diffusely diseased. That's why the surgeons didn't take up. And this is the final result. Though the distal LAD is diffusely diseased, it is perfusing with a TIMI3 flow. Then again, the RCA was cannulated, a functional CTO with the help of a microcatheter. You can see the RCA nicely filling with the impella cannula. You can see venous cannula here. So this again shows there is no robust data on the MCS in elderly population with STEMI, or NSTEMI or the cardiogenic shock. We need to tailor our therapy individual to the individual patient based on the acuity of the clinical scenario as well as the hemodynamics. Let me just touch upon the dual antiplatelet therapy. So when we consider dual antiplatelet therapy in elderly population, we need to look into many things other than when compared to the non-elderly population. So because these patients will have altered physiology and metabolism, they may have a decreased fibrinolysis, increased coagulation, and increased platelet activity as well as endothelial dysfunction, along with comorbidities like anemia, renal dysfunction, cancer, etc. But still, we cannot deter them from recommending from antithrombotic therapy. This is a working group from ESC, which says that the elderly patient should not be denied life-saving antithrombotic therapy simply because of their advanced age and bleeding. We need to assess the risk based on the hemorrhage as well as the thrombosis as well as the other comorbidities like anemia, renal function, and frailty scale. Frailty score is very, very essential in assessing the patient for bleeding risk because they have a less biological reserve. This is the 2020 ESC NSTEMI guidelines, which says that which patient and which agent and how long. Based on the comorbidities and frailty, one can choose the less potent like a clopidogrel agent, whereas if the patient is not having a high bleeding risk and a high ischemic risk, one can go for a potent antiplatelet agent like ticagrelor or prasugrel, which is again emphasized in the Plato elderly patient subgroup analysis. The number needed to treat in a patient with more than 75 years is only 45 when compared to younger population. So that shows the benefit of giving this molecule at least in the early period. Again, the elderly ACS2 trial, which compared the prasugrel 5 milligram with the clopidogrel, showed an equal efficacy. There is no difference in the primary endpoints, though there is an increased risk of late bleeding that I am going to discuss in the coming slides. So to avoid or to minimize the bleeding risk, one needs to use the following strategies: PPI, shortening DAPT, de-escalating the P2Y12, as well as the novel aspirin-free approach from various trials. The shortening DAPT, as from the meta-analysis from 6 randomized trials, showed in elderly patients, if you shorten the DAPT, the ischemic risk is comparable to the long-term DAPT, and of course, the major bleed is very, very less. It may not apply to the patients who are less than 65, who carries a high ischemic risk. Whereas de-escalation, the greatest anti-ischemic benefit is there with the more potent P2Y12 inhibitors in the first 1 month. So in the elderly ACS2 trial, prasugrel 5 milligram should be given the first 1 month, then we can de-escalating with the clopidogrel from 1 month to 1 year, which is a sensible approach in an elderly population with high bleeding risk. The aspirin-free approach, apart from global leaders trial, the other trials like Twilight and TICO trial, all suggested the P2A12 inhibitor monotherapy after 1 to 3 months of DAPT in a HBR patient is sensible and is a most practical approach compared to the 12 months DAPT. So in summary, the 2020 ESC and NSTEMI recommendations did not make any difference in the diagnosis as well as treatment strategies of elderly patients from young patients, but it is recommended to apply the same interventional strategies in older patients as for younger patients. This is a big question and a big challenge because when we encounter in a real world practice of a 85 or 90-year-old, obviously, though the recommendations are so, we have a lot of challenges in instituting the interventional therapy as well as the antiplatelet therapy. So the conclusion is in elderly patients with a high-risk population with unique characteristics like biological vulnerability, we need to have a very practical risk stratification assessment and management strategies. The antithrombotic therapies in elderly need to be optimized based on the bleeding versus risk, ischemic bleeding risk, benefit versus risk ratio, and clopidogrel seems to be the most reasonable option in patients with HBR, and de-escalation seems to be the most ideal thing in eye bleeding risk patients. Invasive management should be preferred regardless of age, but they should be applied with caution. Maybe the smaller studies showed up to 85 years, but we need to consider invasive management in most of the patients with ACS and NSTEMI. Thank you.